I'm Peter Flueckiger. I'm one of the general cardiologists and imaging cardiologists here at Piedmont. And I'm going to talk about the postoperative management of valve patients, specifically surveillance and HALT from an imaging standpoint. So historically, bioprosthetic valve dysfunction and failure has been defined as reintervention or death, but that doesn't accurately assess how these valves are functioning. And really, this needs to be defined by imaging characteristics. And I think as we've talked before, it's more than just high gradients. There's a lot of other characteristics that go into how these valves are functioning. This was a state-of-the-art review from 2022 that attempted to kind of standardize how we define bioprosthetic valve dysfunction for aortic and mitral valve replacement. And one of the key things they kind of recommended was, when do we reassess these valves after procedure? And the recommendation from this review and from this kind of expert consensus was a little bit more aggressive than the 2020 guidelines. So they recommended a pre-hospital discharge echo, another baseline echo at 1 to 3 months, an echo at 1 year, and then annually after that, or anytime the patient has new symptoms. And if you look at the 2020 guidelines, they were recommending follow-up at 5 and 10 years and then annually. So the recommendations from this expert group from last year was to be a little bit more aggressive in screening these patients. And they also kind of tried to define what is aortic valve, bioprosthetic aortic valve dysfunction. They really grouped it into 3 different categories. The first is non-structural bioprosthetic valve dysfunction, and that's divided into prosthesis-patient mismatch or paravalvular regurgitation. There's then structural bioprosthetic valve dysfunction, and that's actually intrinsic permanent structural changes to the prosthetic valve. And then finally, the third category is thrombosis or endocarditis. From an echo standpoint, and not to get really too technical from an imaging standpoint, there's kind of key red flags that we look at when we're looking at these patients on postoperative echoes. And I've kind of highlighted them here. A mean gradient over 20, an increase in the mean gradient of greater than 10 from the initial postoperative echo, an EOA of less than 1.1, DVI of 0.35, and this is acceleration over LV ejection time of greater than 0.32. So as we mentioned before, it goes beyond just what the gradient of the valve is. You really need to look at these other echo parameters to say, is there actual dysfunction within the bioprosthetic valve? When we're comparing these echoes from baseline echo to a follow-up echo, I think the dimensionless index is really helpful to compare. Has there been a change from that initial post-operative echo to the echo that you're reading at that time? So here's a case. This is an 89-year-old male, history of CABG, multiple comorbidities. He underwent a 29 millimeter core valve. He was on Xarelto for oral anticoagulation for AFib. So here's his echo from 2017. He had a mean AB gradient of 12, peak velocity 2.4, dimensionless valve index of 0.43, and an EOA of 1.2. So he came back to clinic with new symptoms. His repeat echo 2 years later showed a mean gradient of 52, significant drop in his dimensionless valve index, and a much smaller EOA. So again, looking at kind of the echo parameters, he had all the kind of red flags that we look for. His mean gradient was over 20. It was an increase of over 10 from his baseline echo. His EOA was less than 1.1. DVI was less than 0.25. And his acceleration time over ejection time was over 0.32, which is suggestive of bioprosthetic valve dysfunction. So I think really taking a multimodality imaging approach, this patient underwent a 4D CT. And here you can see a short axis to the aortic valve. And you can see that all 3 leaflets have significant hypoattenuating leaflet thrombus. And here, if you look at the kind of long axis views, you can see these leaflets are really thick, restricted motion, and you can see that the etiology of this change has been thrombosis of these leaflets. So his Xarelto was discontinued and he was started on Coumadin, and within a month his mean gradient had come down to 15.6 and his DVI had increased to 0.28 with significant improvement of his symptoms. This is a second case of HALT. This is a patient that underwent a 26 millimeter sapien in 2020, came back 2 years later to clinic with a prominent murmur, and his mean gradient was 49, Vmax of 4.5. You can see here, significant hypoattenuating leaflet thrombus on all 3 leaflets, these really dark areas here. And then in the long axis here, you can see that even some of this thrombus is extending superior to the top of the valve frame here. So given his symptoms and the degree of thrombus here, he was actually admitted for IV heparin bridge to Coumadin. He came back 4 weeks later. Mean gradient was down to 12.2, Vmax was 2.5, and his dimensional index was 0.41 with significant symptoms. So almost complete resolution hemodynamically with the anticoagulation. So transcatheter valve thrombus, clinically it's seen in up to 2.8% of patients, but they have done some CT studies that have shown that subclinically it can be seen as high as 10 to 14%. And when we're talking about grading HALT, we really look at what percentage of that leaflet is involved, whether it's 25, 50, 75, or greater than 75%. And the HALT is associated with what we call restricted leaflet motion, or RLM, and that's what's going to lead to the hemodynamic changes. And again, this is just a kind of cartoon showing the degree or severity of HALT based on the amount of leaflet involvement. This study was from 2020, and it looked at subclinical leaflet thrombosis in TAVR and surgical valves. It showed that HALT was a little more common in the TAVR valves compared to surgery. But I thought what was interesting is they looked at the natural history of these subclinical thrombosis. So these are patients that were having routine CTs. So at 30 days, they had 25 patients with HALT, but at 1 year, 56% of these, the HALT had resolved on CT imaging. And similarly, in the patients with no HALT at 30 days, at 1 year, 21% had developed HALT, at least subclinically by CT. So there is some spontaneous resolution, and it can also occur early at 30 days and up to a year later. So what causes this thrombosis? I mean, I think there's a lot of different reasons. It kind of goes to this whole hypercoagulability, stasis, or endothelial injury. Those patients that have low flow states, low EF, low flow, low gradient, leaflet injury during the TAVR. Did they have any injury to the actual TAVR valve? And then do they have any prothrombotic states, or do they have any distortion of the valve that's causing non-laminar flow, lack of sinus washout that may lead to thrombus formation? This was an interesting paper last year. They looked at the deformation of the TAVR valve on CT, and they kind of came up with a couple different variables. They looked at the deformation index, so basically the higher the index, the more of an hourglass shape the TAVR valve was on post-CT. They looked at the neosinus volume index, which is this red area here. And then they also looked at the leaflet expansion. Did the leaflets expand symmetrically with a change in angle very similar between all three, or was it asymmetric where one of these leaflets didn't completely expand? And they basically found that those patients that had a higher deformation index, more of an hourglass feature, were at higher risk for HALT. Those patients that had asymmetric leaflet expansion also increased risk for HALT. And those patients that had a smaller neosinus volume also had an increased risk for HALT, which kind of goes to the idea that if these valves aren't completely expanded, non-laminar flow, you have an increased risk of hypercoagulability. When you look at outcomes, this was a study from 2022. They looked at about 800 patients. They didn't find a mortality outcome between the two, but they did find significant changes in structural valve degeneration by echo in those patients that had HALT. So not all cases are HALT. This is a third case. This patient had a bioprosthetic aortic valve and mitral valve in 2010. His echo in 2019 showed a mean gradient of 20. In 2022, his mean gradient was 39. He had corresponding increases in velocity. You can see here his acceleration time, which is basically the time from the beginning of Doppler signal to the peak. Here was 80. His follow-up was 144. So clearly significant change in the hemodynamics of his valve. Here on echo, you see the leaflets are significantly thickened with restricted opening. So he also was referred for 4D CT. And here you can see on the CT, You don't see any evidence of HALT. You don't see those dark areas on the leaflet, but you do see significant valvular calcification and restricted leaflet motion here, which is consistent with structural valvular degeneration. So his valve was 10 to 12 years old, kind of getting to the lifetime of these bioprosthetic valves. This is the same patient. This is his mitral valve. His mean gradient was 12.4. You can see thickened leaflets here. You can see flow acceleration on color Doppler. You can see that his mitral valve DVI had significantly changed. The delta was significantly higher, and you have similar red flags on echo for mitral valve disease as well. I won't go through all the numbers, but again, it's similar to the aortic valve disease, looking at the DVI, EOA, mean gradient, and specifically the change in mean gradient from the baseline echo to the follow-up echo. And so here's his 4D CT of his mitral valve. Again, significant calcification of those valvular leaflets, significant restricted leaflet motion, and consistent with valvular degeneration. So you can also get HALT on the mitral valve. This is a patient that had a TMVR with a Sapien M3. He was non-compliant with his anticoagulation and came back for follow-up. His mean gradient was a little bit higher than it was at his baseline. And here you can see significant HALT on all three leaflets. So he was switched from the Eliquis that he was supposed to be taking to Coumadin. So in conclusion, bioprosthetic valves have a limited durability. The optimal surveillance isn't well defined, but I think more recent suggestions are to be a bit more aggressive with imaging follow-up. Bioprosthetic valve degeneration requires confirmation by imaging, both hemodynamically by echo and structural by CT. It's more than just high gradients. I think you need to prove that there's actually dysfunction of the leaflets. CT is key in helping to figure out, is it thrombus, is it degeneration? HALT and restricted leaflet motion can be treated with anticoagulation, preferably Coumadin. And then finally, valve degeneration requires evaluation for repeat valvular intervention, whether it's repeat surgery or valve-in-valve therapies. Thanks.